Tēnā koutou katoa, nau mai whakapiri mai. Welcome everyone to this very special event. I am Stacey Morrison, kia ora koutou, and kia ora to everyone here, so kia ora. And I'm really delighted and amazed at how many people have joined us tonight for the latest breast cancer trials Q&A, either watching online, kia ora koutou katoa, or to those of you who are here and brave the cold to come to Auckland Museum. We really, really appreciate it. Now, Breast Cancer Trials is the largest independent oncology research group in Australia and New Zealand, and they've been conducting clinical trials research into the treatment and, importantly, the prevention of breast cancer since 1978. So tonight we're going to be exploring all things in relation to breast cancer in Māori, Pasifika and Indigenous communities, and I just want to honour all of the reasons why you are joining us here tonight. That may be in terms of inspiration, it may be in terms of your personal experience, it may be the spirits that we honour, like my mother and my nana, who always inspire me in these spaces. So I just want to honour and acknowledge what it took for you to join us tonight and why you do that. And to bring us beautifully into this space, I would like to introduce a very important kaumātua from this area, one of our elders who has the mana here at this museum to welcome us properly, traditionally with a mihi whakatau. Kaya koe te wā e te kaumātua Bobby. Tēnā koe.
Tuia e te rangi, tuia e te whenua. Tuia te muka tangata i takia mai i Hawaii ki nui, i Hawaii ki roa, i Hawaii ki pāmama. Tuia ki runga, tuia ki raro, tuia ki waho, tuia ki roto, tuia te here tangata. E ngā mana, e ngā reo, e ngā waka nau mai, haere mai, tēnā koutou, tēnā koutou, tēnā rā koutou katoa. E ngā manuhiri tuarangi, ko koutou ko pai mai nei. Me waiho rā mā ngā maunga whenua, ngā mana whenua anō tēnei o ngā rohe o tātou, o tāmaki makaurau. A rā kia Ngāti Whātua, mā rātou te karanga kia koutou, haere mai, haere mai, haere mai. Haere mai ki runga i tēnei whenua, i runga anō hoki ngā manaakitanga o ngā mana whenua katoa o tēnei rohe. Nā reira ko rātou e karanga ana kia koutou, tēnā koutou, tēnā koutou. Pīkau hia mai hoki ngā huatanga e pāna kia koutou katoa. Mai anō i ngā nohonga o ngā mana whenua anō e rātua no ngā motu. Ke tae mai koutou ki konei, nā reira ka mihi atu kia koutou, haere mai, haere mai. Pīkau hia mai rā rātou te hunga ko whetūrangi tia, hei whakaro mō tātou, tēnā koutou, tēnā koutou, kia ora anō rā tātou katoa. In our beginning waiata and in my welcome, what is this wind that brings different people to this land? What is the shape that comes before me? Kaha te hau, te wawara mai. On behalf of the mana whenua of Tāmaki Makaurau. Tāmaki Makaurau is described as a place that is desired by many. It was fought over by many to have a status in such a place where we are today. We are on this moment called Pukekawa. We are in the midst of Ngāti Whātua, the tribal people of this area. We also acknowledge all the tribal peoples that have lived in this particular place because it was desired by most. And in their welcome and in my welcome I bring their words of saying, haere mai, haere mai, haere mai, especially to our international visitors. No mai, welcome to our beautiful country, welcome to this beautiful city of Tāmaki Makaurau, beautiful city of Auckland. It's not just you, but it's your people that you are here with tonight. We welcome you and your ancestors. We welcome the loved ones that you have farewell as they join that place with our loved ones. And it is tonight that we start looking to the future. Where are we going? How can we work together and look for something that is healing to each and every one of all of us? And so I think you are in the right place and the right welcome to say, haere mai, haere mai, tēnā koutou, tēnā koutou, kia ora tātou.
It's worth coming just for that, wasn't it? Ātāhua, beautiful way for us to start and very appropriate. So now you know we can get into the part where I sit down awkwardly and we begin our kōrero for tonight. Engari I nei, ka huri taku titiro ki a koutou, ngā kai kōrero o te pō. I'd like to welcome our panel who can start to move over whenever you feel comfortable. But please show them love as they do this for us, to share their experiences and their knowledge. Samoan and was diagnosed with breast cancer in 2021 at the age of 60. Thank you for coming tonight and for sharing your experience. To my left here, Ms. Andrea Casey is an Aboriginal woman and has a strong family history of breast cancer and was diagnosed at the age of 48. Welcome as well. And Ms. Maria Marama has a history of breast cancer and is a member of the Breast Cancer Aotearoa Coalition and wearing a fantastic outfit as well. Kia ora, mate. Then we move to Associate Professor Andrew Redfern. He is a medical oncologist from the University of Western Australia, the Associate Director for Clinical Strategy at Harry Perkins Institute of Medical Research, and Consultant Medical Oncologist at the Fiona Stanley Hospital in Perth, Australia. So welcome. Dr. Rina Ramsarup is the Clinical Director of Surgical Pathology at Waitemata in this district here in Tāmaki Makaurau, no mai. And Dr. Rob McNeil is a Senior Lecturer and Health Services Researcher in the School of Population Health at the University of Auckland and New Zealand, and he usually likes to bring his dog but unavailable tonight. So thank you all so much for being on the panel tonight. Everyone who registered for this event, and it is a lot of you, either online or who are here joining us, were able to submit a question to our panel here, and we will be answering those questions tonight. And I get to start with you, Ali. So you were diagnosed with breast cancer in 2021. How did you find out, first of all, that you had breast cancer, and what can you tell us about that experience?
Okay, well, firstly, I regularly go and have mammograms and have done since I was 5. So it was on the mammogram that year that it was picked up.
And when you went through the treatment, were there culturally appropriate information that was offered to you?
There is language that was offered to me, and they often talked about whānau and support if it was needed.
And what did you find helped you on a level as a Samoan woman?
I think really it was about the network and the community and the family as a Samoan woman, and it was also the communication from the staff. The women there were very, in a way like island women, very, very warm and very compassionate, and that really made a big difference.
Well, thank you for sharing with us tonight, and I'll turn to you, Andrea. So can you tell us about your family history of breast cancer and how you were diagnosed personally?
Yep, so I had always been concerned that I was going to get breast cancer because my grandmother had it, both of my mother's sisters, and my grandmother's sister had passed away from breast cancer in her 40s. So I always knew that there must be something genetic going on there. So I'd been having regular screening from 40, and in January of 2012 I went along for my regular screening, and that was all fine, perfectly fine. But later in that year I felt a bit lumpy when I was doing my self-examination, so I went along to see my GP, and she referred me to an imaging place, and I went there and they said, oh yes, where you're saying that you're lumpy, there's nothing, but we can see something somewhere else. Wow. Come back next week and have a biopsy. It didn't go smoothly. I went back the following week, and the doctor said, oh, I can't find anything there. We won't do a biopsy. That's fine. You haven't got cancer. Go away. And it was only that my doctor a month later said, let's do a follow-up. And that's when they found it. So, yeah, I was very lucky.
And thank goodness.
Yeah, because I wouldn't have gone back for screening for another almost 18 months or something. So
it is frustrating though to hear that you were told to have a biopsy and the doctor said, no, you definitely have.
Yeah, exactly. So that was quite frustrating.
So could you share with us here in Auckland tonight, how is breast cancer and women's health in general talked about in Aboriginal and Torres Strait Islander families and communities?
Yeah, so there are so many different and distinct communities in Australia. So it's different in different places. In more remote places where it's more traditional, a lot of those people would not be talking about cancer at all. There is a belief that if you talk about it, you'll sort of manifest it. Also, it's just like the C word, you just don't say the cancer word. It's just not a thing. And so people don't go and get screened because then you have to say that word, and so that will bring it on. In more urban areas, it's probably spoken about a bit more, but still we have very low numbers of women screening from the community. So it's pretty tricky.
Is that so within the community, and now there are many programs that try to adjust that from within the community?
Yeah, so I was actually part of a really good program where it was called the Beautiful Shawl program, and so we went out with a mobile screening service to Aboriginal community-controlled organisations, and women who screened would get a beautiful shawl to take home. So that was really good. So it was like, if you've got a reason for someone to come along, they've done it previously and given women a voucher for a bra, which was really cool. But alongside that, we also did cervical screening and talked about bowel screening, so we were getting everything in there, but it was still hard to get women to speak.
So it's an equitable response, so that we know this is something that is not easy to talk about, so you gave them an incentive.
Absolutely. And, I can remember some women saying, I'm going to tell my daughter to come, or my aunt or my grandma or whatever, because they'll want a shawl as well. So it was a way to get people there, which was really good.
Kia ora, tēnā koe. Maria, tēnā koe te whanaunga. Nice to see you again. Now, you also have a history with breast cancer. Can you tell us about your experience of being diagnosed and how you found out you had breast cancer?
Kia ora. Ei te tūtahi, i me hatu ki te mana whenua, o rātou whakatau I wainganui a tātou, no reira tēnā tātou katoa. He uri tēnei no Ngāti Whakau e Tūhaurangi, te tautoku pāpā no te kuki aranei, no reira tēnā tātou katoa. I was diagnosed with breast cancer in 2015 and I was shocked. 14 months prior to that I'd had a mammogram, and when I went to see my doctor, because I found a lump on my breast, and he said to me that it's probably an early cancer, or it's a cyst. Well, that proved incorrect. I was actually stage 3, grade 3 breast cancer. So that was devastating. My journey through the cancer system is probably not one that's experienced by Māori women in general. I was fortunate enough to go through the private health system. So in that system, I basically could dictate and say what I wanted. That's not the experience of many Māori women. So in that I built a strong relationship with my oncologist and my breast surgeon. One of those things is that I'm quite a strong person, but a lot of people aren't, particularly when they're in vulnerable states. Not to say that I wasn't vulnerable. So my experience is very different. When I entered the public health system, because I received Herceptin after 2 years of going through the system, private system, I then entered an environment that was very much what Māori women would experience. So lack of support, nothing around me that was culturally significant for me to relate to as a Māori woman. So again, I was quite assertive, but I think my experience would be different from many, because in the private system you get what you pay for. In the public system you don't necessarily get to choose what methods of treatment that you can have.
Yeah, I really appreciate how you acknowledge that that's an unusual experience and that you can compare them both. So they're quite different.
Definitely. And so the cultural support, the lack of cultural support, I should say, or engagement through both systems is quite really in your face, because no one there in the private system really looks like me. And so the support to my whānau, Stace, was really important, but we didn't have that. We just had each other, and I was really grateful that my family and my friends came through with me on that journey. So for Māori women, our whānau are the main support, but for those that don't have whānau support, it is really, really challenging, because you meet a system that doesn't look like you, and if you have historical trauma because of the experiences that you or your whānau have had in the health system that's not responsive to us as Māori, it can be traumatising again. So I just feel for some of the women that don't have an opportunity to speak up, that they will take what they are given without asking questions, and that's because we're vulnerable. We think we're going to die. That was certainly my experience, and I jumped into the system saying, give me everything. And along that pathway I did look at rongoa Māori, went to see a tohunga, did all of those things that could culturally ground me in who I am as a Māori woman. Again, not many, I'm kind of speaking because I'm guessing here, but you don't get that opportunity to actually say what it is that you want to do. I'm really open. I told my breast surgeon and my oncologist that I was going to be having vitamin C and things like that. And of course what they talked about was the fear of what those other treatments might do in relation to the chemotherapy, and whether or not that would affect the treatment that I was receiving. Had I had another choice in terms of would I have gone down a rongoa Māori pathway, I think if I was already in the system around rongoa, such as the marae, like Manurewa marae provides rongoa treatment and things like that, I think I may have gone down that route, but I was scared, and I had medical insurance, so I thought, why not? I'm going to do everything and get everything that I'm entitled to get. But that's also the same that should be offered for Māori women and Pacific Indigenous women in our public health sector. It's just not responsive.
I think you brought up this element of historical trauma that is going to be something that's an ongoing kaupapa that we want to talk about tonight. So we'll take every opportunity we can because it's important. It's part of why we engage or don't engage. And I just want to acknowledge rongoa Māori, if anyone doesn't know, is traditional medicine, and tohunga are our cultural experts as well. So thank you so much for starting us off talking about that. Now, Andrew, although breast cancer survival rates have improved over the last 20 years, statistics show that women and men from Māori, Pasifika and Indigenous communities have a higher breast cancer mortality rate than people with European ancestry. So Hilda sent us a question of why you think the statistics of mortality are higher in our populations.
Yeah, thank you. So, I mean, my experience, I work in Western Australia, and we've done a lot of work looking at this question in the West Australian Aboriginal women. And then we take information from the Maori and the Pacific Island women in New Zealand to learn lessons there where we can. I think when we first started working in this space, it was very much an assumption that it was socioeconomic, so people who were poorer, they were reluctant to engage with, say, Western medicine. They waited longer to go for diagnosis and so on. When we've looked in Western Australia, we've seen those are only mild contributors for the most part, and certainly the Aboriginal women I work with and treat, I've not found as much reluctance at all in that space. It's very similar, providing you take time to explain things till you've got an agreement that you both know where things are at. It works quite well. So we started from a point that even when you look at those things as a big unknown space where we don't know why there's a gap, and that's also holds for the Maori and Pasifika women in New Zealand. And we've found that I think a lot of researchers assume there's one thing and they're going to find that and it'll be amazing and everybody will go, that's great, sort things out. And what we've found is there's a lot of, rather than the holy grail, it's lots of small egg cups essentially, where there's probably 6 or 8 different contributors. We've found that certainly the Aboriginal women get more aggressive types of cancer. We found that they get more side effects from the same drugs because of the way their bodies handle drugs. Found their immune systems works differently with cancer, which can make a difference. And we've also found that the nutrition, vitamin D is quite an important vitamin in cancer control. We found vitamin D levels are very low in Aboriginal Western Australians, and that's probably making a difference as well. So all of these things all add up to quite a big difference, but each one's a small contributor.
Interesting, because we will talk about genetics, but what you were saying is there are lots of different things that can impact, and it could be ancestral diet, it could be the diet that they can access. All of those things contribute.
Yeah, I mean, it's when we sit in Perth, it's very easy to say, eat plenty of vegetables and get exercise, but even some simple things like the cost of a lettuce in some of the remote Indigenous communities is 4 or 5 times that, and it's very hard to live a healthy diet. The cheap food is the poor quality food, and that all adds to risks as well. So we're now starting to work on facilitating kind of healthy choices and making that accessible to everybody much more.
And it also just might be really different from our ancestral diet and what our bodies are, used to having consumed. We don't do that anymore. That's not how we're living, as you say. So a question now to Rena. Julie has sent in a question on whether genetics plays a part in the differences between those mortality rates in different ethnic communities. For example, Ashkenazi women have a higher risk of breast cancer with the BRCA1 gene mutation. Just ask you to move that microphone a little bit closer so that we can hear you.
Thank you, Tēnā koutou. Yes, that's a question that has been raised a number of times, and unfortunately I do not have an answer for you tonight. We don't know what genetics play in Indigenous women, Maori and Pacific women, and that's because we don't have enough data. Dr. Logan Walker, who's a researcher at Otago University, he's set up the New Zealand familial breast and ovarian cancer study, and it's part of a global study. And in chatting with him, he also agrees that we need more data, and he's trying to answer that sort of question. The one exception I can talk about is we know that stomach cancer, familial stomach cancer, is more frequent in Maori, and it's related to a gene, a CDH1 gene. And we also know that gene is related to certain types of breast cancer, lobular breast cancer. So, there's a little glimmer of hope. There's information coming in, and hopefully we will get more information to answer those questions.
Because we have a question from Emma, who's a Māori cancer coordinator, and she says she's often asked about getting genetic testing, and she's asked how accessible is this genetic testing for these communities, and is it worth it?
So genetic testing for the public is done by New Zealand Genetic Service, and they have sort of sites in major cities. And there's also private genetic service, but that's expensive, obviously. So it varies. So women that do have breast cancer has an easier pathway because they usually come up in a multidisciplinary meeting. The type of tumor is discussed, their age, different criteria are taken into account, and they get referred via the breast specialist clinics. For well women or women that don't have breast cancer, it's a more difficult pathway. Family history comes in, very much more like Andrea. Family history is important. And then GP, the conversation with the GP, conversation with other health workers, and then referral. The referral along that pathway is usually via the GP. And it can be more sort of torturous or difficult.
Yeah, so I went through that because my mother died of breast cancer at 45, and my nana had cancer as well, but the breast cancer was a secondary cancer, so that meant I didn't qualify for free genetic testing, which seems like it's a pretty high threshold. Like, you know, yours is obviously horrific, and so the threshold is pretty high, isn't it, to be able to get free genetic testing?
Yes, it is. There are guidelines. We use the Australian guidelines. And you have to fulfill the guidelines. The problem, obviously, it's a limited service, and so it's very difficult, and long waiting lists like everything else in healthcare.
Does that mean that there's not as much information for them to even look at because we don't, like, do we have a lot of genetic testing?
Yeah, I mean, when people are referred and people meet the criteria, yes, there is genetic testing, but it's just going down that pathway to get to it, to access it.
Has anyone here had genetic testing? How long have you been waiting for?
Yeah, waitlist.
9 months.
Yeah.
I think that's interesting. We've got, if you can't see here, there's about 5 people who have here.
Yeah, and it's not, I mean, genetic testing is, because it's a small service and they offer genetic testings along all tumour streams, so not only breast cancer, but stomach and other cancer types, ovarian. So it's quite overwhelming to the service.
You know, one thing that probably affected that was Angelina Jolie.
Yes.
So we went, okay, great, we can find out. But that's not actually the case, is it?
You have to have a really strong personal family history before you can start down that pathway.
Or be as rich as Angelina Jolie.
Yeah. Should I ask a show of hands how many people are as rich? No. Now, Rob, we have a question from Teresa, who says there are no Māori or Pasifika nurses at the hospital where she was treated. And as a result, patients from those communities didn't feel very comfortable talking about their treatment. They didn't have help to translate information. They didn't have people to help them at home or with transport. So she has asked whether there needs to be more culturally diverse staff in hospitals and the health system to help patients, and does this improve patient outcomes?
Thanks. Yeah, it's a big question.
Yes.
You know, it's not an unusual observation that she's made, and you know, I'm really lucky. My research job is to sit and talk to patients a lot, and I hear about these sorts of things all the time. You know, like our health workforce is way overrepresented by white people, by New Zealand European, and by overseas trained staff, and Māori and Pasifika are way underrepresented, and that's, I think, to do with the way we, our education system and our training systems, and I think there is widespread recognition in the health system now that we need to fix this, but it's not an easy fix and it's not going to be a fast fix, but there's some things that we could do now that would really make a difference, and that's thinking about the staff we have at the moment and getting them more culturally safe and culturally competent. And I think both the safety and the competency aspects of it are really important. Like safety's about people being aware of their own culture and how that impacts on other people's experiences. And competencies about kind of, you know, just the everyday skills to work with people from other cultures. And everybody can learn those things. I'm just recently started learning Te Reo Māori, and I'm so glad I'm 53, and it's taken me all of that time to finally get up the courage to do it. And I, in some ways, feel ashamed of that. But you know, like everybody can start their journey at any point doing that, and I think that's the same for our healthcare workers. And I know that there's like everybody who I work with in the healthcare system is absolutely doing their best to try and and help this situation. So that's one thing. And another thing that we could do is actually get people who aren't healthcare workers to work with these people. And so there's a lot of work going along kind of in what we'd call the navigation space. And that's helping people navigate their way through what is a very complicated system with transport and going to appointments and understanding what's happening at appointments. So advocacy and navigation.
I know that's the term for whānau ora navigators. Are you specifically speaking about whānau ora or creating these roles for people to navigate?
Yeah, so I think the whānau ora navigators are a fantastic model for how it should be done. There's also other navigation models, like I guess more traditional kinds of Western ideas of how navigation would work that are happening. But I think any kind of navigation is useful, and it doesn't have to be people who are medically trained or have a health profession background. It can be anybody, but they do also need to know how the system works because the system is complicated.
So that sassy auntie is what you're talking about, isn't it?
Yeah, and it could make a huge difference to outcomes because if you can get people more engaged in the services, they're going to be more likely to attend appointments, they're going to be more likely to start their treatment, finish their treatment, go to follow-up appointments, and that's going to have a real impact on health outcomes and quality of life for people.
Kia ora. Could I ask all of the women here who have experienced being the patient, when have you had culturally appropriate staff or ways of supporting, or if there is none, then tell us that as well. But how have people made a difference in the way that they've approached you when they are health professionals, and how has that helped on a cultural level? See, there's no ready answers. I don't think everyone's going, it's great, nothing to worry about.
I think I've said my piece around lack of cultural engagement, and I support what Rob was saying about needing to increase cultural competency. But I actually think it's bigger than that. I think there's a systemic issue here, and it's called racism. And I think the system needs to address that. And the way you change that is actually to have your policies in that all align with people's rights to be able to access healthcare. I think you can make a difference at your management level, your governance levels for organisations that exist. I think there's opportunities there for health providers to engage with Māori providers and Pacific providers because they know how we roll really, and the fact that that is non-existent or exists in some parts, then the system will always remain the same. So why not work with external agencies outside of the cancer pathway to encourage Māori and Pacific and Aboriginal women to engage, because we are dying. Māori have the highest incidence of breast cancer. So I think it's more than that. I think that there needs to be policy changes, and under the Treaty of Waitangi, it's the Crown's obligation to promote and protect Māori health and also health equity for Māori. So are we doing a good job of that? I don't think so. Aroha mai, over to you, colleague. Kia ora.
Are you here to speak truth?
Interesting about where the demographics are. My mother was in Middlemore Hospital with something else, and she had Pasifika staff, which was really lovely and really great, and I think we do need more. I also think as Pasifika people brought up in the generation I was brought up in, we don't actually ask a lot of questions. We are quite gregarious in a group. We are quite outgoing. We are quite shy. There are many times I've been in situations with my family members where they don't actually ask questions. So I think it's really important for them to feel comfortable to get these dialogues going. I have seen the way sometimes they have been spoken to. So I think education and everyone endeavouring to see everyone treated equally as a human being. And I really think for Pasifika people, we are shy. We often don't ask questions. And it's having Pasifika staff to be able to engage with is very would be very, very useful. Again, that's rather a large thing to accomplish. We know what our nursing situation and everything like that is in New Zealand. And yes,
I think you bring up a good point about Middlemore I won't name other hospitals, but it's a different situation. Is there something you'd like to add?
Yeah. Can I just say something about Middlemore? Because last year and the year before we did a project looking at the delivery of chemotherapy at Middlemore Hospital. They've just recently shifted the chemotherapy treatment to there, so that all Māori, all breast cancer patients who are from counties Manukau can be treated closer to home. And not only are they closer to home, but they're, the staff there are much more, there's a lot more Māori and Pacific staff at counties as well. And so it's just been a game changer. And, they did some modelling about how many patients they needed to treat down there based on the numbers who were coming to Auckland Hospital. And when they set up the unit, there were a lot more patients who actually went there than they were expecting, because the theory is that there were patients who were choosing not to have treatment because they were having to come to Auckland. But shifting it away from a big hospital is just another whole mess, like trying to figure out how to make this system that doesn't work for people to do things differently, like having Marai-based treatment or other models of treatment is really complicated.
Yeah, and just for anyone who doesn't know, in terms of distance, it's from Middlemore to Auckland is about 40 minutes, an hour on a bad day, an hour and a half on a worse day. So it's quite a barrier. Is there anything you'd like to add in terms of having staff who look like you treating you?
Yeah. So when I was diagnosed in 2012 at the hospital that I was at, I had identified as Aboriginal, and I had 3 surgeries and lots of treatment, and not a soul from the Aboriginal Health Unit came to see me or reached out, which was disappointing. But now I have to say that where I work, part of my job is Aboriginal Hospital Liaison, and so I am one of the people that goes along and makes sure that every Aboriginal and Torres Strait Islander person who comes through, who has identified, is reached out to. If they come into the hospital, then the other Aboriginal Hospital Liaison and myself make sure that we go in and meet them, and they can opt into our service or not. We can sit in on appointments with them, organise transport, liaise with community services and all sorts of things, and sometimes there's a lot. But I think we make a difference to people's outcomes.
Kia ora. And I just want to add, in terms of one of our practices of karakia, of incantations and of experts coming in, I have witnessed that quite a few times, and hospital staff being accommodating and being good and seeing, well, actually the numbers are different after that happened. I don't know why, but it's working, so we're going with it. So that what we believe in is what we believe in. And so when that is engaged with, I know that it's, a lot of staff are open to that. But like you say, you do have to be the person who asks for it. And so, Rena, I've got another question. And actually, we're summarising some of these questions because they're coming up a lot, and so it means they're important. But we have a lot of questions from people about breast screening. And we know that people from Māori, Pasifika and Indigenous communities have lower screening rates than the general population. What do we know about why this is? And I'll probably open this up to everyone. And what impact does it have?
Yeah, thank you. Yes, definitely the data has shown that that screening rates in Māori, especially over the years, have been very low. There's a number, as Andrew was saying, that it's not one factor. There's multiple factors that can play. I think education and awareness around breast cancer, the awareness around breast screening, and its positive impact, the access to breast screening. I mean, it's sometimes difficult. The mobile units help a lot to take breast screening to the communities, and I think that we should do more in that respect. And I know Breast Cancer Te Reo is working to do that together with Breast Cancer Foundation. So I think that that's important, because you go as we've heard, that you go not alone, but you go with friend and whānau, so it makes it much easier. Communication, telling people and talking about breast cancer and the fact that screening is available and is free is also helpful. So I think there are a number of factors. Obviously, the socioeconomic, the transport, time off work, childcare, all of those things play an important role in going for breast screening. I think there's things that we can do from both sides to increase it. Pacific women actually, prior to COVID, the coverage and the screen rate was very good. In fact, it was higher than the target rate. But unfortunately, we had COVID. We had, especially in Auckland, where we have our biggest Pacific Island population, the rates really went down because of all our lockdowns and screening units were closed down. So the rates have not yet picked up. It's picking up, but it hasn't gone back to where it was. So, hopefully that will happen in time. And so I'm hopeful that for Pacific Island and for Maori, with increased communication and awareness and education, that the rates will pick up. Impact, well, we know from our data, 30,000 voices that was published last year, that screen-detected carcinomas or screen-detected cancers have a much, much better outcome than symptomatic ones. So if you look at 10-year survivals, it's 95% versus 85%. So the impact is quite huge.
You just mentioned the target rate. Do you know off the top of your head what that is?
Yeah, so coverage target rate is 70% and over. So to get the cost benefits and the health benefits from screening, you should cover 70% of the population.
And is that from 45 in?
That's what we in New Zealand have it from 45 to 69 or 70 right now. We're hoping to push it to 74. There's a lot of advocacy around it, but government is not biting yet.
Yeah, we'll also talk about lowering it for our communities.
I think that conversation has started, and I think that where we would look at is target lowering of ages, because otherwise the system gets overwhelmed and then the main group gets overlooked. So we want, when we come to the younger age group, it's more a targeted screening. So yeah.
And of course we can have self-checks that maybe leads to having more of a follow-up. But I mean, I know I was advised to start at 28 because that was 10 years before my mother was diagnosed. But like you, Maria, it was because I was able to pay for it. If you can't, then you're not going to engage with it in the same way. And I guess if we can follow this up, Andrew, what do you see in Australia with breast screening for Aboriginal and Torres Strait Islanders?
Thanks. Yeah, well, it's lower. The rate is lower in the Aboriginal women compared to non-Aboriginal women. It's been certainly in Western Australia. It's a huge state. It's the size of Europe, essentially, as we like to say. And if everything's centralised in WA, it's almost like you're going to France for your mammogram if you live in Scotland. And so we try and make sure every country, so to speak, in a European sense, has it. And so there's been the mobile units are a very big thing, and also there's been a big focus. We have an Aboriginal reference group that Breast Screen WA has put together with an Indigenous representative from each of the regions, and they have travelled to some of the areas and built a network, and they almost go door to door looking for people when the van is in place. I think the screening rate, the target is again about 60 to 70%, and it's come up from about low 30s to low 40s with those initiatives. The other thing to say, it's interesting about, we've looked at how good a mammogram test is, and we've looked at something called the breast density, which is how dense the tissue is. And if you've got low breast density, mammogram's a really great test. You can see cancers very early, very easily. If your breast is a lot denser, you may need an extra test. And Indigenous women have a much higher chance of having low breast density, so a mammogram's a really great test. So when those women that do go for a mammogram, they'll be getting more benefit than the non-Aboriginal women. And as my Indigenous colleague Leanne says, finally some good news at last.
Yeah. I remember being delivered that news that my density was going down as I moved age groups. Thanks for that. Now, Andrew, Ani has asked whether there is enough clinical evidence for Indigenous, Māori and Pasifika people to have breast screening at a younger age. So, as I kind of alluded to, and should that be expanded? But I guess, can we just focus on if our communities have a higher incidence, well, you know, our mortality rates are so bad, and if it's happening younger, is there enough data to speak to that and urge to have it done younger?
It's a great question, and something that, and a breast screen is a huge structure, and we're really looking at both that and broader questions. Everybody gets the same screening. You get to 45 in New Zealand, 50 still in Australia, up to 70, 75, and you get invited for screening. It's the same for everybody, but people have very different cancer risks. That's not done if you've got heart disease risk. You know, you look at the risk and you do things to adjust to that. And so we're starting to think we should look at the ancestral origin and the risk there, and that would certainly apply there. For marriage should be considered for earlier screening. Look at breast density is another thing, and other risk factors, the general family risk. And maybe we can build a picture of each individual person and say when you should start breast screening. And certainly if you're married, then that would suggest maybe you should be considered for earlier screening. Well, it's not probably enough yet to move it to everybody to an earlier age, but certainly we know a lot about risk, so we should put it all together and give everybody the best sort of plan for themselves.
And so what's the free screening program in Australia? What is the age range? So from 50?
It's from 40 to whenever, so as long as you want. You're invited. It was from 50 to 70, and it's recently become 50 to 75, and seeing that people who are in very good health are getting breast cancer in their early 70s. But you can request, you can ring up Breast Screen and ask to be asked to have a mammogram from 40, and you'll be automatically invited. So once you hit 40, then you can go for mammograms for the rest of your life, but you're only invited for a segment of it.
Right. Great invitation, right? So, to all the women here who've had this experience, what is your take on breast screening and our engagement or supposed lack of? Why does that happen, and what are the barriers, or what you've seen is working and isn't working?
I think one of the barriers for Aboriginal women is the shame and embarrassment at times about getting your breasts out, to have your screening, not knowing what to expect. So...
But didn't you say how many people in this room have seen your breasts?
I said that there's at least 3 people in this room who've seen my boobs. Yeah. 2 of them there and 1 up the top.
So you're not having that problem at the moment?
No, I don't. Look, I personally don't. Like, I could walk down the street and that'd be fine. But that's because I feel like all of Melbourne has already seen them. Yeah, there are a lot of women who are very embarrassed about it. I think now that there's more sort of information out there about how when you go through breast screen, it's always a woman who does the screening. I think that makes a difference. But then you know that should something be detected, you might not then have a woman as your surgeon, or, you know.
Yeah, thank you. Happy o kōrua whakaaro, what about you two? Any thoughts on breast screening?
Oh, lots. I've got lots to say. Let my colleague have a bit of some airtime before I launch him.
That's okay.
Well, it's a really interesting question, and I often wonder about it. I wonder what contributes to it. I certainly encourage my family to do it, and obviously because my cancer was caught through breast screening, there was a series of ads on TV that I thought were quite effective about the family, the importance of family and looking after the mother, the sister, the brother. And I think that was quite important for Pacific people because we're very family orientated. I mean, most people are family orientated, you know, it's not to make the difference, but they were very effective, you know, because it wasn't up to the one person, it was the father, the children, look after the mum who looks after them all, you know. It's a really interesting question, and I would actually really like to know the answer because it would be really great to be able to engage more Pacific women to undertake.
Yeah, I think it's got something to do with the approach and how the approach is made. and where that approach is from. So if you've got a good relationship with your GP, then they would probably encourage you to seek breast screening. And as we know, Māori a lot of Māori don't even go to a GP. So there's an approach that needs to happen. I think there needs to be targeted messages. So kind of just for Pacific people in particular, we kind of put them into one box of Pasifika when there's actually 14 or more nations in that. So it's not a one-off approach that needs to happen, and I think we need to be really mindful of that. The other is I agree there needs to be the extension of the breast screening category from 40 to 75. I like what Australia's doing. If it's kind of going at 40 and you're there for the rest of your life, that would be amazing. But that doesn't happen in New Zealand. But take one from the Australians; they're doing a good job then. So I think there needs to be more advocacy around that. I know there's a big piece of work that's being done by Breast Cancer Aotearoa Coalition as well as the Breast Cancer Foundation around increasing the age and decreasing it from 40 to 70. So I think that's a start. But I think we just need to look at the approach of how we get these messages to our people. I agree with Rena around there needing to be education and good communication to our people. And again, those messages really need to be targeted. But I don't know what the causes are neither, and I think there needs to be more research around that. And the way you do that is you actually come and talk to us. You talk to Māori and you talk to Pacific, Fiji and Tonga and Samoa. No, don't lump them all together, and ask them why they're not going for breast screening. Whakamā is part of that, embarrassment. And the other is like Ali was saying, women are busy, and usually we put everybody in front of us. We are the po, we are the strong force in our whānau, and we forget to actually look after ourselves. So by the time we get sick, it's kind of like it's too late. So we need to do what Counties Manukau did in 2017 or 19, I can't remember, but they did a big campaign for Māori women around do it for your whānau. So I think those sorts of campaigns need to come back in, but there needs to be targeted approaches, otherwise Māori women will continue to have high rates of breast cancer.
Yeah, no, that's very useful information, and we even not just with breast screening, but I suspect it's probably right actually. not just for screening, but also when we get into other aspects of treatment. One of the things I've personally observed from treating Aboriginal ladies is it's not uncommon that they'll shorten, or if they do decline the treatment, it's often for family reasons. They're looking after grandchildren or children or their nieces and nephews, and they often put the family ahead of themselves, and so certainly educating the family to turn it around as they need. Whereas the non-Indigenous women tend to go, right, I've got a serious problem, it's me now, and we'll step forward. We see that less in the Aboriginal ladies, I think, and do try and encourage, obviously, a reshift to that priority. But it's an important thing that the family, as well as the doctors, integrate with the family to do that, I think.
Nice. I hope it's okay to mention, just tonight I was speaking to someone in the audience who has gone to their marae and got everybody to get amongst it, and has 8 of their whānau who have gone to have their screenings now, because they're an amazing advocate. So sometimes, but you know, it takes that po, it takes that strong woman who's leading it, and then the whānau to wrap around and, okay, I'm just admitting I've had 2 texts saying I'm due for my mammogram and I need to go this week, I promise. But I do sometimes see the messages, like for Pasifika, around cervical screening, they're so much more fun. It's like go in a van and have a great time, and let's have and ours are all heavy, like ooh, whakapapa, you know. So I like your point around let's be really specific about who we're talking to. And I'm talking to Rob right now because I have a question from Siobhan, who has asked whether there has been any initiatives or research undertaken to make cancer screening services more culturally safe and appropriate to encourage people to attend.
Thanks. And Maria's just helped me answer this. You know, I'm not an expert in the breast screening space in terms of what's been going on to try to make things better. But I do know about the social marketing campaigns that you were talking about, and they make a big difference. And I think we need to keep doing them. I think we tend to do them as a one-off, and then we leave it for years, literally, before we do it again. I know there's also been a recent effort to try to rebrand the mobile units They've got some fantastic imagery on them now, and they've made them kind of a much more familiar looking space. I know that Dale Bramley, who's the head of innovation in the new Te Whatu Ora space, so that's our new kind of combined health system.
Mothership.
The mothership, yeah. He's just recently put out a report in the last 6 months saying that we need to review how we've got the breast screening structured to make it work better for Māori and Pasifika. So I think there's something that's going to happen there. And on that side of things, I do know more about what's going on in the lung cancer screening space. We don't currently have a lung cancer screening program, and that's another really important thing for Māori. And I've been really lucky to be invited on to an advisory group that's made up almost entirely of Māori researchers, and we've been working towards pushing the National Screening Unit to set up a lung cancer screening program. And we spent a whole 18 months talking to Māori, both in Auckland and in Northland, to ask them what they would like, how would they like to see this screening program look, and what the sorts of things would stop them from going there or get them to go there. And so I'm not sure that kind of depth of work was done when the breast screening program was set up. And so I think hopefully maybe when they review it, we might be able to do some of those projects.
Kia ora. I would like to go now actually to a member of our audience who knows this is happening, so we're not scaring anybody. And we have a question from the audience here from Karina, and it may be addressed to Rob, but everyone can have a think about if they've got something to add to this
Please
as well.
do.
Thank you. Why are participation rates in clinical trials lower in culturally and linguistically diverse communities, and what are some of the challenges?
Yeah, this is a huge question. I'll try to break it down, and I'll be very happy if people jump in. We talk about socio-economic factors, and that's definitely part of it. Indigenous populations tend, Māori Pacific, other Indigenous populations tend to be in lower socio-economic groups, and so anything that's a financial barrier is going to be a significant barrier to participation in clinical trials. And so that's about taking time off work, it's about childcare, it's about transport and travel, because it's not just the distance that people are travelling, it's actually the availability of some sort of transportation for them. There's all sorts of things, and some trials cover some of these costs, but they don't usually cover all of the costs. So they might cover transport costs, but they're unlikely to cover things like childcare. So socioeconomic factors are important. Cultural preferences and customs, just cultural differences. Like Maria said before, that the system's racist, and that sounds like a really harsh thing to say, but I think it's a fair thing to say about the system, is that we've come from a history of our systems being set up in a very Western model, and I think there's widespread recognition in the health system, among health care workers, that something needs to change, but trying to figure out how you then go about changing it is just such a mammoth task, and we're trying to change ours at the moment, and it's a mammoth task. The other thing is, language and communication is another big thing, particularly for Pasifika, and because English is much more likely to be a challenge, but Māori as well, and other Indigenous groups where English is not their preferred language. I think that's a huge issue, and the other thing is health literacy. And that's a big thing, and I think the way the system's set up at the moment assumes a much higher level of health literacy than most people have. I've worked in health research for quite a long time. My wife's a psychologist, so she's in healthcare, and we struggle to navigate our way through the health system with our level of health literacy. let alone how other people are going to manage. So, have I?
Can I add?
Yeah, sure.
Just wanted to say also that a lot of our clinical trials are sort of global trials, and so the number of people that are chosen as part of the trial from New Zealand being so small are very small. And so you already got a very select number, you've got a small number, and then we're trying to be diverse, and so it becomes much more difficult. So, as a pathologist, I have to provide tissue samples, so I know, how many people take part in trials, and it is a difficult question, and especially it should be easier, and it should be we should do something about it to get more people on trials. Yep.
Sorry, another thing in the sort of clinical side of things is that a lot of trials have exclusions for comorbidities. So that's when people have other health conditions, and we know that Indigenous populations are much more likely to have those. There's also exclusions for non-English proficient people as well. So you're essentially excluding anybody who isn't proficient in English.
So you're looking for diversity and then ensuring there's no diversity.
Yeah. And we wouldn't get away with preventing people access to healthcare because they can't speak English. So this is not too different. I mean, this is essentially healthcare. So it seems unethical to me.
Yeah. And so this is the point where you find out why my friend calls me Māori Hermione. I put my hands up for trials all the time. So when I was, I was carrying my babies, because I just wanted to go, okay, the Māori mum who doesn't smoke, I want to say all of those things. My son got a concussion. They said, do you want to do a trial? I go, he gets a free MRI? Yes, definitely. But that's because I can drive around, I can do that. I have a level of health literacy that is really just because I've got really brainy mates who are doctors and go through the pain of MAPAS and being treated like they got some easy ride when they have a harder ride, if you ask me, and they're so needed. Gosh, they work hard. And you have to justify their existence and justify that people are saying you got given the answers, which is just incorrect and ridiculous. Right.
Yeah, it's not a subject I knew a lot about, but I gave a talk about this just before coming here, and I had to learn an awful lot of things I didn't know. So I now know at least 10% of what Rob knows, I would think. But certainly the health literacy and knowing what a trial is and what cancer is a start. And then there is certainly been identified bias or racism in the system sometimes. And I think, the system's busy, and sometimes even where somebody comes for a trial and the patient says, no, I'm not interested in the trial, I know my days got a lot shorter all of a sudden, so there's almost that. And I think we need to put more resources into making it incentivising, recruiting people of diverse backgrounds. And then the other thing that I picked up in my million article study was that having people positive affirmation from appropriate cultural groups. So if you know somebody who's been on a trial, or you meet somebody from your community who's had a positive experience in a trial, that makes a big difference. If you're being told you should go on a trial because otherwise it's really bad, that's a negative sort of affirmation towards pushing towards trials that doesn't work as well. And so and then it becomes a bit of a problem because you've got less culturally diverse people who go on the trials, then people who are culturally diverse are less likely to know somebody on a trial, and so therefore it just goes down around and around. So we definitely need to make more resources available and incentivise recruitment at the health service level, and then we need to work harder to bring in people with useful personal experience and weave it into the culture of the communities where the trials are being conducted, rather than just have it in the big shiny places.
Nice. And Maria, could I ask you to unpack historical trauma a little bit more for people who maybe don't know that term, or how it manifests for Māori, for many people who, this, as you just said, the system wasn't designed for?
I guess there's many examples of historical trauma for individuals, and kind of one of those examples is being played out in court right now through the inquiry that's happening into the abuse that happened for young people many years ago. And I think the trauma that I talk about is the experience one has when they go in. I mean, the basic is you go into a hospital, you've got a sick child with you, the person at the front desk looks at you, you're all anxious, and I want to see a doctor. They go, what's your name? Do you belong in this DHB? And you go, I just need some help for my child. And they're incessant about, you have to meet the criteria to actually live here. So you don't get seen, your child's sick, and you go away thinking, what am I going to do? So that's a trauma. One, because you can't protect the child. Two, the person at the front is a barrier to you being able to access the services. And the other is that you're Māori or you're brown, and the person at the front desk is white. So they're viewing you from their cultural perspective, and you're viewing them from the fact that I can't even get to see a doctor because you're stopping me from doing that. So that trauma then carries on with you through every interaction that you've had in the health system, and in any system really. The other is your uncle, your mother, your father goes into hospital and they die. And so then Māori and Pacific people see hospitals as a place that people die because we don't understand. So there's an education component that has to happen. So all of those incidences or interactions that we have that leave Māori or Pacific people, or anyone really, in a state of feeling powerless, feeling vulnerable, feeling that they can't impact the system, that they can't change it, puts you in a space of trauma. So every time you interact in any system, in any program, you always think, I'm not going to get it. And then you get the instances where people turn up to emergency departments because they've had that experience. Now they've got a dying person that they're with, example. They are then quite hostile to the person behind the desk because they actually really need to see a doctor. And then that plays out with a security guard removing them and no one getting any care. So that's how I would unpack historical trauma in terms of how the health system operates. And it is an experience that many of us in this room have had, and many of us would like to see the system change. So that's been happening for a long time. Has it changed? I'm not sure, but I think there needs to be cultural competency and capability built around how we engage. It's like the same thing of, how would you like to be treated if you were on the other side of that desk, with respect, with a listening ear. And I think our system and our programs that we have in place to circumvent that kind of need a bit of a look at, to be honest, because we've been putting up with this for quite a long time. So has it changed? I'd say no. Will it change? I'm hopeful about that. But yeah, kia ora.
Kia ora. Is there anything you'd like to add in terms of what is a barrier to engagement when you have these, these experiences that have already been traumatic?
Yeah, look, I think there's a lot that happens, and along similar lines, if your mother or your grandmother had to give birth on a veranda at a hospital because they weren't allowed to go inside because that's where the white people were, that's a scary thing, and that's something that sticks with you because your family tells you that. And then possibly the baby or other children were taken away, so you're not going to trust anyone. So then you take your child to the hospital, and then you're worried that as soon as you identify, they're like, oh, we have to get, someone in, we have to get in the authorities to take the children away. And it still happens. That's scary. And then the other stuff about clinical trials is, people wonder what is going to happen with their tissue sample. Are they actually just part of a big, an experiment like it used to happen to our people back in the day,
Yeah, no, that's a really valid question, and just so people know, these are not just things you made up, those are things that happened. Absolutely. As part of the, not only just what you've been told about it, but it becomes a cellular trauma. You know that's what happened in your family. And Rena, this question actually relates to this. In New Zealand, how is data collected about breast cancer in Māori and Pasifika communities? You started to speak about the samples you need to take, those kind of things.
Yeah, so for clinical trials, there's consent, so samples that are used for clinical trials are all consented and by the clinicians. So that's so we're in the last step of that process. But how data is collected, so in New Zealand, and we have the National cancer register, and we also have the breast screening Te Reo register. So breast cancer data is collected, but it's very limited. It's very few data fields. It's not an extensive database, so it's very difficult to answer some of the nuanced questions that we are asking today. It's quite difficult to answer it from the amount of data they collect. So the more complete and more extensive data is in the Te Reo, which is the BCF National Breast Cancer Register, and that's going now from 2000, and it's got an extensive breadth and depth of data, right, that covers the whole pathway, right from diagnosis all the way up to treatment and follow-up and outcomes. So we have now a mature data set, which is, as I said, quite deep in data. So we can now make some informed decisions, can inform us of how and where we should be making changes, what sort of treatment changes, what sort of care changes, what sort of quality changes that breast cancer patients need. But we've always known it, but we've not had the data to support it. And so this register, which is funded by Breast Cancer Foundation and is governed by the Clinical Advisory Group and by the Register Trust, has this information that we can use to inform us on better breast cancer care.
Kia ora. Aileen from the Breast Cancer Foundation is here as well. Tēnā koe. Thank you for all of your mahi. And could you remind me, when that data is collected, do women have to agree to that, or is it just happening?
So when we started the register, it was a consent. You had to consent for it, and currently what happens is that, and at that time, every patient that was diagnosed with breast cancer had a patient information sheet which explained exactly what was going to happen and what sort of data and what was going to be used and where it was going to be stored and the privacy and all of the ethics around it. So that still happens. Patients do get the information. But what we found early on was that in around 2011, 2012, when we did an audit on the data that was being collected, was that we were missing out a proportion of our patients that presented late, that we couldn't consent because they were too ill, or they died as soon as they came to hospital, or didn't come to hospital. And so we were missing out on a big proportion of patients that actually had bad breast cancer, and so we weren't getting the full information. So we changed we applied to HDEX, the ethics, and we changed to an opt-off process, again with full consent and patient information around what is happening, and we've had very good response. It's quite transparent how and where they can opt off being on the register, and we have very few. We've got about 1.5% now. From 2020, that register has gone national, so we're getting all patients that are diagnosed with breast cancer to be on the register, and that's going to be very powerful for everybody and to inform us.
So that's a 2020 COVID time, so there's a lot that's at play, isn't there?
Yeah, I think that what's happening around the register is more communication, more awareness of what the power of data, and so I think that we need to step it up, and I think we will do that.
It's such a good point, because how many of you are researchers here? I can see you with your pens. Yeah. But I really appreciate the fact that a lot of other people have come as well. But when we say data, you have to have a really high level of health literacy to understand why that matters and what that can contribute to. And when you're busy and you're just surviving, that is maybe the last thing you're going to do.
Can I just say, Stacey, that I think there's the whole data sovereignty kaupapa is really real for Māori, and certainly there's a move to ensure that data is used in the way that it was intended, as well as the whakapapa that goes with that data. So any tissue, any blood sample, and I was part of a working group for the Breast Cancer Foundation actually, around talking with Māori women around who owns their data, whether it's a blood sample or anything. And their response was, it belongs to us. It's our whakapapa. So anything that you have of us belongs to us. So I think that the opt-off process, there's a key issue in that. And I think for me, it's to do with literacy, whether or not Māori and Pacific women or whoever actually know that you're on this. So you may not know that because you don't understand. And what does that mean for you? And does that mean that all of your data stays with that one organisation? And as researchers, you all know what I'm talking about. But even if it's anonymised data or information, for Māori that we interviewed, they said that that data still belongs to them and they've only given it for that one purpose. So this whole blanket consent to have your data used willy-nilly, and I mean that in a very assertive way, is not actually appropriate for Māori and Pacific. I think we need to have control over the narrative that is being put out there by non-Māori or Pacific researchers. Not to say the research shouldn't happen, but I still think that we need to be in charge of and involved in the narrative that's actually said about us, because many of the research that is out there is all negative. So the narrative is not being controlled by us. The whole social context in terms of who we are and how we be needs to be considered as well. Anyway, he taki anō tēnā, but kia ora.
No, he pai. Do not apologise for offering.
I'm just taking up all the airtime. I'm conscious that others.
No, actually, you're all talking a little bit too little. We're actually good for time. Ka te pai. Yeah.
I think something that concerns me is that data in Australia, I know, isn't a true reflection of what's happening, because so many Aboriginal and Torres Strait Islander people don't necessarily identify when they go to see a doctor or go to a hospital or whatever, and that's because of that racism and that intergenerational trauma and that sort of thing. And so it's if you don't look traditionally Aboriginal or Torres Strait Islander, it can be easier to just go in there as a white person rather than identify yourself and then have questions asked and things. And it can be questions as simple as like a time when my daughter went to somewhere, a health service, and they said, what's your name, what's your address? Oh, you're Aboriginal, you're not Aboriginal or Torres Strait Islander, are you? And she said, actually, yes, I'm Aboriginal. And they sort of said, looked her up and down and said, you don't look it. Things like that. So
yeah, you've talked about that a couple of times in terms of choosing to identify. So that's a real issue with the community.
It is. Yeah, it definitely is. Yep, it can be much easier not to.
Yeah. And just on that intergenerational trauma, I forgot to mention that. That means that the experience that, say, your mother or my grandfather has had in the health system, if it's been negative, that story gets told for generation and generation and generation, and that never changes. The narrative never changes unless something's disrupted and that person has a positive experience. So that's the intergenerational stuff that happens in terms of whakapapa. It's with you. And if you can change that narrative by ensuring that people have a positive experience, then you'll see some changes, I'm sure, in the way inequities will reduce.
I just want to add that it's not even just what we've been told. I've seen a physical response from people that they don't necessarily know where it came from. And to me, he mea tuku iho. And I see this in what we call language trauma, that people get to a point where they literally cannot speak and they don't know why, and they cry and they go, I'm so mad, I don't know why I'm crying. But you don't have to know the story to know the feeling. And that is one of our understandings of what we receive as uri, as descendants, that we feel all of that. And I can see, Andrew, you're ready to tell us a bit more about the Australian experience as well, and the way data's collected?
Yeah, I'm sitting here realising I don't actually know the answer to the first part of the question. I just have an understanding of I believe that certainly cancer is a notifiable disease. So my understanding of the Australian system, acknowledging I only see people once they've already got cancer, so I'm not talking to people until they've already been diagnosed. But I'm not aware that we have consent or an opt-out system. Anybody who gets a biopsy or any kind of sample that's confirmed as cancer, it's notified. So the pathology service has to then notify the cancer registry of that state. That does remove the element of consent, which is not a good thing, but it does mean we don't have gaps as well where we're not getting to people and we wouldn't even be able to ask them and give them the option. So that doesn't remove, of course, that issue that's been brought up of identifying. And I've certainly had patients who've identified with me as being Indigenous, and I said, "Oh, you're not identified previously." Said, "Oh, well, I was concerned I might not get as good a service." And we're trying to build systems in WA to, one of the things is we kind of need to know where the Indigenous people are that are being diagnosed, so we can add what we hopefully better services and turn it into a positive experience. But and that removes a little bit of consent to know people are Indigenous and then approach them, even though they then have an opt-out. So if you need to consent in order to speak to people, it's very hard to speak to people, sort of thing. So we've sort of tried to work that fine line of balance between consent and knowing where people are, so we can offer them help. So. But in Australia, coming back to the original question, data, cancer registries collect a basic level of data, has already been said, and that gives you essentially a list of people to look at their cases and how well they've done. So it's just the beginning of a research project that then we look at each individual person's case and journey and build patterns of what's going right and wrong and try and fill in those journeys and make them better.
That's such a good point, because there's data and then there's narrative and there's understanding, there's kōrero. Yeah, so that's such a good point. I'll turn to you, Rob, as we start to close up. How important is this collection of data to inform policy and services and change?
I think it follows on well from the last questions, and I'm not going to repeat the information about the breast cancer registries. I mean, I think we've got a great advantage here over Australia in that we do now have, since 2020, a truly national breast cancer registry, and it is really important to use these data sets for policy and service improvement. I've got a PhD student at the moment who is using the breast cancer registry data to look at to look at unusual differences in breast cancer surgery and treatment, including systemic treatment and radiation treatment between different regions of the country. So just to take away the surprise of his thesis, if you're in the Waikato, you're much more likely to get breast conserving surgery than a mastectomy. Than if you live in Auckland or in Wellington or Christchurch. And we don't understand why that is. And so I'm pushing him, he's an epidemiologist and he just wants to crunch numbers. I'm pushing him to go out and talk to the surgeons and to the medical oncologists and the people who are actually doing these treatments to try and figure out why there is such a big difference. And I think that's the other part of my answer, is that it's great having these registries with all of this detailed clinical information, but to actually make sense of how we can use it to make a difference, we need to get out there and talk to people. And that's not just talking to clinicians about why they're doing breast conserving surgery or not. It's about talking to patients and whānau about their experiences of their care, because those data sets don't hold that information, and those stories are truly treasures. I am incredibly lucky to do what I do as a job, which is to listen to people's stories of their care. I cry a lot, but the data that I get is genuinely gold. And other countries do a better job than we do. In this sense, the UK have a regular cancer survey that they do. They have a cancer patient survey that goes out to a lot of cancer patients on a regular basis, and they use this information to do real service improvement stuff on top of the registry kind of big data analysis things that have been done. So I think we've got a wee way to go here to get to that point.
That's a really good point.
Can I just add? I know we don't officially do it, but I think that that Breast Cancer Foundation, Breast Cancer Cure, Coalition, all of them do lots of surveys. I think that a lot of them are related to breast cancer patients. I'm not sure how much of it should now be expanded to whānau and family and friends. And I think that that's one of the things that we should be looking at.
So let's look at opportunity and hopeful ways to end this discussion. I want to leave it in the hands of the women who've had this experience, and this is your story. Would you like to share with us anything that makes you hopeful for the future, or anything you'd love for us to work on so we can have a more hopeful future?
I think that there are a lot of amazing projects and programs out there that are starting to make a difference, but it's a long journey. The number of women screening isn't going to jump dramatically anytime soon, but I see that we're heading in the right direction. Of course, COVID threw a spanner in the works, let's face it. But I think that there's some good things going on out there, but I think it's about Aboriginal-led programs. Yeah, definitely.
By our people, for our people. How about you, Holly?
So as someone that sort of wakes up and has a shower, and I look at the big scar I have on me and some of the pain that goes with it, as a human being that has had breast cancer, I hold a lot of hope that other people don't get it, and the high Indigenous rates, that through having these discussions, people looking at the data, having the dialogues, as you say that we do, that the percentage can be reduced. And that's my hope, and that's, I feel, for us sharing our stories. And so that's me.
And thank you for sharing. It's massive. And we really, really appreciate this time and this offering that you give us. Maria?
Aspirational. Well, a huge reduction in the incidence of breast cancer for Māori women would be an aspiration, and the way in which that's approached. That needs to be as a collective, not as individuals. We're not individuals, we're part of a hapori, we're part of a hapu. So that would be my aspiration, is come and talk to us. I'm not here to actually provide researchers with the answers, but what I am here to say is that Māori want to be in control of their narrative, and I've already said that. There needs to be more Māori and Pacific researchers doing research on our own people, and so we need to increase our level of capability in that particular area, because the way in which we can solve this is actually to put that into the hands of Māori and Pacific. We have our solutions, we know what works for us, we know why we're not going into hospitals, we know why we're not going to have our breast screening done, but sometimes we just don't want to share that with you because you don't look like us. And so it's important to upskill researchers, it's important to increase our cultural capability in the health services, and it's about policy change. It's about this policies being made by the Ministry of Health and in every other health organisation needing to address the issue of inequity, because that's the issue that's at hand here. We've talked about racism, we've talked about a number of things today, so I just hope that those things get addressed and get addressed quickly, so we don't have more Māori women and Pacific women and Aboriginal women dying. Nō reira, tēnā tātou katoa.
Mauri ora. Mauri ora kia tātou katoa, mauri ora kia koutou e mātaki mai nei I tēnei kōrero, I tēnei wā. Ka huri taku titiro kia koutou, ngā rangatira o tēnei pai. Thank you all so much to our panel. Feel free to express your gratitude to Ali, Andrea, Maria, Andrew, Rena and Rob for being on our panel tonight. Joined us here today, and everyone who's joined us online, thank you for taking this time, and everyone who asked questions that I read on your behalf. And this Q&A has been recorded and will be available on the Breast Cancer Trials website tomorrow, so the team will send everyone a link to be able to watch and to share. Breast Cancer Trials is committed to improving the outcomes that we've all talked about for every person diagnosed with breast cancer through clinical trials research. So they look to the community as well to help support this important research. And so if you or your family or friends would like to make a donation, you can do that via their website at breastcancertrials.org.au. But what you've done is a humongous contribution by coming along tonight. Tēnei ka mihi kia koutou katoa, te whakaeatanga e, te whakaeatanga e. Tēnei te kaupapa kāia, tēnei te wānanga kāia. Ko te Māori o te kaupapa, ka whakamoia, ko te Māori o te wānanga, ka whakamoia. Koa ki runga, koa ki raro, haumi e, hui e, tāi. Thank you all so much. Kia ora.
Kia ora.